it sounds like it's kind of a hodgepodge, though. Is that inaccurate? I mean, it sounds to me like this is an ever-changing, it's part of your practice, which is, okay, once we have diagnosis, once the treatment is this versus that, I'm on oral oncolytics. Now my differential on adherence is forgetfulness, et cetera, lack of access to being able to procure it because of financial circumstances or coverage. Now I'm down that pathway, and there's a whole myriad of ever-changing patient adherence programs with respect to patient access, copay, foundations. That sounds like a lot of work.
It's a lot of work, and I think one thing that, again, having that capability and that commitment at the practice level certainly has helped patients. And discussions that we've had with payers, they are interested in the level of support that we, the practice, provide to our patients. So tracking, having metrics around how much copay assistance, free drug, foundation support, all the different vehicles that can help a patient afford their therapy in a practice, tracking that and being able to communicate their story of doing the right thing for the right reasons is important. Because what I'll say is, not all stakeholders in this space, some of the mail order pharmacies will say, don't offer that level of support for patients to uncover all the financial support. And we, with our quality standards, have got the commitment to provide that, and we call it passionate financial support.
So just the whole construct, though, then, I mean, as Christina was mentioning, 10 to 15 years ago, we got into a mold, into a steady state with how we treated cancer with respect to radiation or infusion, essentially. Then comes along the oral oncolytics and totally different insurance construct, particularly in the elderly, right? Because most of these patients are going to be Part D or legacy pension products, right? And so is this Part B, Part D? How does that change as far as now I've got these oral oncolytics, we're used to procuring it this way, we're used to billing it this way, now we have these products. Similar circumstance happened with Zoster in the immunization space where, wait a second, it's covered in a different place, but what did that mean then for this being mostly covered in Part D for these practices? It's sort of a change of direction, right?
Yeah, and again, that goes back to what we were speaking to earlier in our conversation, the fact that there's, the practices have been very good at doing IV therapies for decades. You know, they've been in practice for a long time.
That's what they're used to.
And then all of a sudden, here come these orals, and they came in a flurry. And we realized that they're efficacious. You know, there's adherence issues, there's toxicities. We need to help manage that. And now there's this financial piece that is totally different.
So if I'm the office manager, I call up Mike and say, you need to come over here and help, because I've got Christina saying that we want to use these and they're good for our patients, but we don't know how to handle this. We're used to this other way of doing things, right?
Yeah.
I mean, is that what you experienced you went through?
Yes. And our physicians say, well, we want it. The patient needs it.
And
Make
so,
it happen.
Figure it out.
What sort of additional people and offices, and I mean, you have financial counselors now, you have staff that try to figure out patient assistance programs. I mean, what's the additional work and infrastructure and people now that need to be in place in order to successfully allow these patients to thrive on these treatments?
So in our practice, we have a patient financial advocate, financial counselor, and she helps with both oral and IV.
Okay.
But then in more of our medically integrated dispensing, we have staff there that help with our fills within the practice, but also help all of our patients for outside.
Right, because now you've got pills somewhere in the practice.
Yes.
You've got to figure out how to get those pills.
Yes, and that's what they
May
do.
or may not be from the same wholesaler mechanism, whatever else. Now I've got to figure out how to send a claim for these new products. So I've got maybe new software. I need to figure out now how to have people in services that are on the phone doing proactive outreach, perhaps, or virtual, or something that's coordinated with the practice. I mean, it sounds a little bit like practice transformation that's sort of occurring here. Does that sound right?
So we have the IV side and the oral side within the practice. You're working all together, but you have to have staff to handle all your oral therapy.
Sounds a little bit like the Matrix. So we've now got the green pill and the blue pill.
Like for example, in our practice at the University of Minnesota, in one of our clinics, we have over 550 patients on oral oncolytics. And there are 3 financial coordinators that break up the alphabet in handling for these patients. So whether it's a patient with a commercial plan, a Medicare patient, underinsured patient, non-insured patient, these personnel need adequate training to be able to identify which foundation should I go to or which resource can I go to be able to find financial support for these patients, because these are thousands and thousands of dollars worth of medication. And obviously, it's really important for those patients with aggressive disease that you want to start as soon as possible. And then you run into problems also, again, supporting the medically integrated systems. You run into problems when, there's from year to year. So when patients that may have insurance changes, that is gonna, the new insurance may require something, may require a renewed PA. During the year, if patients have a job shift or a job change, new insurance plans, get on a spouse insurance, anything like that, again, all support why, having that one umbrella for patients, it's really, really important in their care.
What about transition from private living circumstance to institutional care or assisted living? Is that another place where you have this, okay, now I got a whole new group to coordinate with and frequently in this area? Okay, so let's say I'm a patient, again, I come into your practice. Christina, I meet with you in the exam room, you tell me, the bad news is you have CLL, the good news is here's these options now. You can still go down to your summer home in Phoenix. And then you say, so it looks like you're on X commercial plan, and I'm going to have you talk with this patient assistance person, and what does that typically look like for me? It looks like I might get assistance from the manufacturer. It doesn't, based on my income. What are my options if I'm sort of in the non-public payer space?
So first, we always check with the insurance. Most commercial plans, most insurance require prior authorization.
Okay.
So first of all, staff go through obtaining a prior authorization.
All the typical work that says, yes, they should
Yes.
get this medication.
Yes.
Sort of P&T sorts of stuff, okay?
Yes, and then we check how much the copay would be, because again, the drugs are expensive, so copays are usually higher. And then we look at all possible options for the patient. Is there a copay assistance card through the manufacturer? Are they eligible for that? Is there any foundation assistance, any grants they may be eligible for? And then the other thing we look for then are free medication through the manufacturer.
Okay, so I can go to the manufacturer for a program to reduce my out-of-pocket. I can look at a local foundation, or I can ask the
International
manufacturer for grace, so to speak.
Yes.
Okay,